My name is Tom de Potter. We're here in the EP lab of the OLV hospital in Aalst in Belgium. We're a tertiary care facility operating with about 22 cardiologists, and we're performing currently about 1,000 ablations per year. Slightly less than half of those PV isolations for atrial fibrillation. My practice is mostly the atrial fibrillation workload plus the patients with complex ventricular arrhythmias. This patient is a 66-year-old patient with paroxysmal atrial fibrillation, refractory to antiarrhythmic drugs. He was treated with beta blockers and then later with class 1 antiarrhythmic drugs with flecainide without sufficient success. Patient still reports symptomatic episodes of paroxysmal atrial fibrillation and has an otherwise structurally normally heart. So he was referred for pulmonary vein isolation as a potentially curative approach to his symptoms. So we did the vascular access. We're ready to start a procedure. So relatively young man with paroxysmal atrial fibrillation. We have 2 sheets in the groin and we will do a single transeptal puncture. We moved to single transeptal puncture a few years ago because it's of course much easier provided that we are reasonably certain that we will isolate the vein on the first attempt. Because if you don't isolate the vein, then you need to start switching between the balloon and the lasso and it becomes very inconvenient. But because of our high isolation rates, we switched to single transeptal about, I'd say, 3 years ago. There we go. We'll put a pigtail to perform a rotation angiography to make a 3D reconstruction of the left atrium. Meanwhile, I'm gonna put our pacing catheter in the ventricle. It's the catheter we'll use for phrenic nerve pacing later, but at this point we're gonna use it for ventricular pacing so we can make a nice acquisition during ventricular standstill. So you can see the long wire in the vein. We like to use a wire with a straight, soft tip because we feel it is easier to go deeply in the vein safely. And now over that wire we're going to put the steerable sheet. Note how the tapering between the dilator and the sheet is the exposed piece of the dilator is very short. The tapering is very good, is very smooth, which means that it's usually easy to enter the skin. Sometimes we make an additional extra cut, and in particular it's easy to cross the septum with this sheet, 12 French inner diameter. So here it doesn't cross the skin. I will open the incision here, and then you will see that we won't have any issue to cross the septum. There we go, approaching the septum now, and without any effort, I simply cross, you see, I'm holding it with 2 fingers, and we're through. Trek er maar uit, Kathleen. So now we're going to flush the sheet, check an ACT and prepare the balloon. So I want to show you something which I think is quite spectacular. Geef mij de ballon. Which is I can do this whole preparation by myself. The whole system has become very easy to set up. And although it's of course nice and convenient to have an extra pair of hands, if I need to, there's no problem to do this all by myself. And this is because of a few simple improvements in this system. Nobody got an award for this for sure, but they really help. They really help a lot in terms of preparation. While our technical support, Eric, is doing the preparation and is going to prime the system, I can start flushing, I can start infusing the D2O, and I really don't need an extra pair of hands. I really don't need extra help, which is, of course, convenient. I'm going to prepare this already. You can see Eric priming the system. And Eric, as before, I would like you to hit run pump already. And what it means is it will allow me to flush the system, and it's going to bypass the bubble detector. You see, so it's running now. And despite the fact that it's full of air, of course, it doesn't go into alarm like the previous generation did. So I can already start, and I can simply fill the balloon, back flushing the air. So it's going to run back to the burette, of course. And the way it's designed, the air is just going to filter itself out. So you can slowly see the balloon filling itself with air. And you see, if you look now at these tubings, you can see the air running through, you see? And it's simply bubbling up. It's genius. It's my favorite feature of the system, actually. No, the rapid mode is my favorite feature. It's one of my favorite improvements in Excalibur. It's so convenient. Yeah. Okay, and there's the water, the D2O. Voila. It's really a zero concern setup. I don't need to mess with tiny air bubbles that I can't get out or worry about them. It's zero effort. I fill the balloon, insert the camera, deflate, and we're good to go. Here's the fiber optic. You can see that it's been reprocessed in this particular patient. We tend to reprocess the fiber optic camera until it becomes afunctional, until it's no longer giving us the quality we need. Again, you see the D2O coming out of the port here, which means I'll be able to insert smoothly. There we go. This is for you.
Thank you. Now we connect again the endoscopic end of the endoscope to the endoscopic attachment on the console, like this, and now it's connected. This wheel is for sharpening. Now you see I can, if I have, let me see, to make it sharp, and this is for the blind spot movement, but we see it on later on.
Groin puncture 1526, it's now 1546, 20 minutes after groin puncture, we're ready to start our ablation. Single-handed, no extra help for the balloon setup. So we're ready. As always, I'm going to try to do a procedure that is as standardized as possible, that follows the same template, follows the same general approach as we do for all our balloon procedures. You can see that this nice man has a common ostium on the left. That's typically not a problem at all, provided you appreciate it, provided you understand the anatomy. It's not a problem at all to occlude this with the balloon. What we're going to do firstly is gently advance the balloon. Here you can see it coming out of the sheet right now. And I'm going to deflect a little bit on the sheet, stay clockwise, stay posterior, so that I end up in the vein and not in the appendage. And then let the tip find its way into the vein. Just by gentle push, you see I can deeply go into the vein, confirm that I'm nicely in the vein, do it in a very atraumatic way. The tip is very flexible, very floppy. And now I can pull back a little bit. And what I'm going to do with the marker for the orientation is I'm going to open the marker with its open end to the inferior aspect. So we have a good frame of reference for the camera view. It means the camera needs to be in the 6 o'clock position, and that's what just happened on the live camera view. You saw it. We rotated the camera so it matches the marker orientation, which means it's now anatomically correct, which means inferior is inferior, superior is superior, right side is anterior, left side is posterior. And I'm inflating the balloon, and you can see and appreciate occlusion appearing. You can see different branches of this common ostium, but first thing we're going to try is find out if we might not be able to occlude it completely, and it looks like we're going to be able to with a single balloon position. I'm inflating the balloon even more, and you can see that most of the antrum is occluded. The only questionable portion is around 7 o'clock inferiorly, so I'm going to deflect the sheet a bit and see if I can accommodate that, if I can fix that, let's say. Looks like here we can inflate a little bit more. There we go. So here we can appreciate a 360-degree occlusion of this common ostium. So at this point, of course, we should be able to do one big swoop. I can rotate the laser beam to have a trial run, if you will, here to see if it goes through. Here I need to be a bit careful because on this side the vein is a bit more proximal than here. So what I'm going to do is start here on this end so that the tricky part ends up being last on my ablation. I'm sorry? No, I want to do counterclockwise and do the blind spot in the end. Okay, so we're ready here. Counterclockwise 13 watts. We've used 13 watts in most of our rapid mode ablations. So far, we feel it's more than sufficient to make transmural permanent lesions. We have rarely used 15 watts. And here during the ablation, oh, nice here. Did you see the asystole? So here we have a vagal response. You can see on the ECG, but you can see visually, of course, on the camera, you can see the loss of contraction, which is typical for vagal ablation, for ablation on the anterior aspect. We're ablating the ganglionated plexi and we're causing a vagal response and an asystole. It's resuming by now. It's very easy to see on the endoscope, on the endoscopic view. You can also, in this particular case, appreciate nicely, I think, the edema we've created, the lesion we've been forming, which is the milky discoloration of the tissue. If you look at the arc we've already ablated, you see that the tissue looks different from the tissue that still needs to be ablated. And what I'm doing here is pulling back a little bit on the laser, so I'm coming more proximal. The rotation is automatic, but the depth of the laser is manual, so I'm pulling back a little bit to stay nicely where I want to be. Here, I have to say, I'm going to check again. Okay, now we can easily see it's safe. Quickly pulling back the camera to visually check there is no blood under the shaft. And then we can continue the rotation. I mean, the ablation, I'm not rotating the shaft, of course. I could, but we chose not to. Now we don't see the laser because it's behind the shaft of the camera, of course. And you can still see that it's rotating by these little markers on the proximal portion of the shaft. And there we are again. There I need to stop because here we're touching blood. Here I think we are a bit too proximal. You see here where I come out. So what I'm going to do is go a bit more distal and then continue here to make sure we have overlap. So here I'm at the edge of my blind spot. And you can see where we started the lesion. You can see where the white discoloration starts. And that's where I want to stop my lesion. There, we'll go for some extra overlap. Extra time needed is 5 seconds, and it's going to make sure we don't need to come back here. There we go. Okay, here we can deflate, and we should have isolated the entire left portion in one single circle. So we can move to the right. For the right side, we'll need to prepare phrenic nerve pacing, of course, as always. Putting back the catheter into the sheet, and now I'm rotating, opening the curve so as not to be traumatic, of course, and now pointing to the right side. I'm going to give it a little bit of curve. And then again, let the catheter do the work, let the catheter find its way into the RSPV. This is RAO view. There we go. Now we're pointing to the RSPV. This there. Very nice straight path, which is typically the configuration that gives you the best occlusion if you have nice coaxial alignment of the balloon from the steerable sheet right until the distal end. If it looks like this, it's typically easiest to get full occlusion and perfect visualization. So let's inflate here. Note that again I've made it so that the opening of the marker points to the RIPV in this case. So that's where we should find the RIPV on our endoscope, on the endoscopic view. Balloon is a bit in the vein. I pulled out a little bit, and here we can start to see the ostium forming. It's going to be a pretty nice occlusion here. There we go. Different branches of the RSPV visible. And I'm inflating the balloon a little bit more to get rid of these tiny little lines that you see around the balloon, which indicate intermittent loss of contact. We're a little bit out of focus, I think, on the camera. Yeah, that's better, thank you. Okay, here again we can do 360 ablation, but we might as well show you what repositioning looks like, so let's do that. Let's start here at the proximal end, at one side of the blind spot, let's say, and we'll do 270-degree ablation, and then for the last portion we'll reposition so we can visually confirm that our position is appropriate. In this position we'll do clockwise, 13 watts. And we need to start the phrenic nerve pacing, please. Can we do that? Also the phrenic nerve pacing, you will appreciate on the endoscope. You can see the movement of the diaphragm. If we get the pacing now, so far no capture. There. If you look at the red line of blood actually at the edge of the endoscope from 12 o'clock to 5 o'clock, let's say, not the vessel itself, but the blood pool further out, you can appreciate that it moves at a rate of 1 per second, which is the phrenic nerve pacing rate. It's a diaphragmatic contraction we're visually confirming, which means I won't even have to feel, I won't have to put my hand on the diaphragm to know that we still have capture. I'm starting the ablation here. And as always, I'm holding my hand on the laser manipulator so I can adjust the depth of the ablation in the ongoing encirclement if needed. So here, for example, I'm going to push in a little bit to stay a little bit closer to the vein. As long as I do this smoothly, the continuous motion of the laser is going to make sure we have overlap. As long as I don't excessively move in or out during my encirclement, I have overlap. You see we're touching the edge of the blood pool here. Sometimes for a tiny second the laser target changes to red at its edges. If this would become worse, I'd have to stop here and do something about it. But fortunately we've passed this region now and we can simply continue. On the X-ray you can appreciate our very proximal position, so it's a very safe position in terms of phrenic nerve damage. And here we're going to go under the blind spot, so here is where I want to stop. And here we'll rotate. So I'm going to rotate the balloon and Eric is going to make sure the anatomy stays the same by adjusting the camera position. He's going to use visual cues for this on the screen, visual landmarks. There you go. For those interested in reprocessing, please also note on the endoscope tiny dots. The tiny dots on the screen on the bottom are technical defects in the endoscope that you don't get with a fresh endoscope, but are a result of reprocessing. So here you can nicely see the lesion. You see this white line that's, I'll put the pointer on it, here. This is the lesion we've made, and here we need to continue. So here I am going to continue, and we can go under this portion. Very nice. So I'm guaranteed to have overlap here. I can easily visually confirm my previous ablation position. And now, of course, because we've rotated the shaft, the blind spot is no longer in the way, and we can also guarantee that we're doing it safely, not ablating in the blood pool. So if you're wondering, is this is enough, if you don't know for sure anymore where you began, what we can also show you is the review, which is very quick and easy to do. We'll do it after this ablation. We're going to show you what the system recorded in terms of the ablation positions we visited, so that we can convince ourselves that we've made a full encirclement, or if we think we need to do something more, we can do a little bit of touch-up. So let's do that now. Here we started, you see we started at the 6:30 position at best, and then I stopped there, but we have overlap. And here we go way beyond 6:30, again, nice overlap, so it should be okay. So we deflate the balloon. And now we'll go to the inferior vein. ACT is 345, by the way. ACT should be above 300. You see the sheet falling into the RIPV. It's a very strong sheet, the laser, the cardiofocus sheet. It's a steerable sheet that allows pretty significant downward torque and tension and flexion without breaking pull wires. So we've actually had very good experience in doing RIPV occlusion and ablation, despite the fact that sometimes it's anatomically challenging. Here you can see two branches, and what we'll need to do here is pull the balloon a little bit back so we're more proximal, and then increase the size of the balloon so we can get these two branches in one swoop. Inflating the balloon. I can do this myself here with the little handle. And you see now I've increased the size of the balloon. I'm outside of the vein now, and I can advance, push a little bit to enhance the contact without overdoing it. And there. The fact that the balloon is compliant makes it easy, of course, to assume unnatural shapes or unconventional shapes and still get good occlusion, even if anatomy is challenging you. Here we can do the same as in the other veins. We can go behind the blind spot. We'll start here, do clockwise ablation, and then finish with the portion behind the blind spot. Pushing a little bit on the laser to stay away from this blood superiorly. And there, I'm also pushing a little bit on the balloon to enhance the contact. Again, you can see a nice lesion formation, nice edema formation. The top half, let's say, of this vein clearly looks different than the bottom half. Clearly has undergone some edema-related changes. It's one of the very nice things about laser ablation, of course, is if you have a view like this, your energy delivery is not dependent on contact. There's literally nothing that can go wrong in the ablation in this position. In terms of lesion efficacy, if you can see the tissue and shine a laser on it, you will always make the same lesion. You will always deliver the same amount of energy to the tissue. And here again, because it's visually quite obvious, I chose to go behind the blind spot. Probably not recommended in early experience if you're not fully confident yet, or if you're not fully acquainted with how a typical laser procedure should go. It's probably not recommended to do this in the first batch of procedures you do, but once you have a stable workflow, it's entirely feasible. There we go. We're behind the blind spot. You can see a very nice donut. You see this donut around the vein, which is the lesion we created, which here visually is obvious. It's hard to conceive, hard to imagine there would be a gap in this lesion. So let's try to confirm that. Let's take the balloon out and put our lasso catheter in the vein. Okay, here is the LSPV, or I should say the left common, which is clearly isolated. There's a nice far field A and a far field V, and then no PV potential. We'll show you the running screen in a second to make it equally convincing. There you go. And I can manipulate the lasso a little bit, but you can see there's no change. If you want, at the end of the case, we can do pacing maneuvers. For me, it's convincing, but up to you how much you want to do. Okay, this is the RSPV, clearly isolated. Let's go to the triggered screen again to confirm it. Okay, here we go, clearly isolated. Nice far field A on halo 910 before the P wave, confirming that we're not too deep in the vein. We're picking up right atrial far field with no PV potential. And then finally the RIPV, this nice donut that we made. If this one isn't isolated, then we've got an issue, but of course it is. And typically in the RIPV we don't see right atrial far field, as is the case in this patient. So all veins isolated, 16-12, less than 50 minutes, single-handed. So we did 209 seconds on the left common, 157 seconds on the RSPV, 167 seconds on the RIPV. I think typical times for individual veins are around 180 seconds. We did slightly less for those two, and then the left common was a bit larger, of course, 210 seconds. At the end of the procedure for hemostasis, we very much like to use a figure of 8 stitch, which is of course a simple needle and a thread, which we're going to put under the sheets, but still of course in the subcutaneous layer, like so. And then we're going to cross over the sheets and do a second subcutaneous stitch, but this time over the sheets, which gives me a Z. And if I close this, I will have a 8, of course. I will have a continuous loop. So the idea behind this is, once I close this, I can use the skin, the subcutaneous layer, to exert pressure on the vessel. The vessel itself is not in the loop, but the skin above the vessel will be used as a form of compression to provide hemostasis, which is very, very simple, very cheap, and very efficient. I'll show you. So if I pull out, you can see that if I let this bleed, of course, there's no hemostasis. If I simply pull on this structure, you can see that it's completely dry now. I'll put the blood away. You see it's not bleeding anymore, and this is because the skin is compressing the puncture site. So what I'm going to do is close this now, and we're going to leave this in place for 4 hours, and then the patient can start moving around. Very simple.
The main improvements for Excalibur were in terms of handling. First of all, the balloon compliance, the increased ease with which you can get through occlusion of a vein, because you can really get off-angle pressure on the balloon, and the balloon will sort of conform to the ostium. And then the other advance, which is really silly when you think about it, but it's all the handling, the preparation. For me, it's if you have a high volume lab and you focus on efficacy and every minute counts, the changes that have been made, they save us about 15 minutes per procedure. And it sounds like such a small thing, but it's such a major improvement. It makes life so much easier. Of course, the fundamental thing about laser, the really truly unique feature about laser, has been there from the beginning, which is for me non-contact ablation. The fact that you make a lesion and you do not depend on your stability on the tissue to generate that lesion. If you can see the tissue, you can shine on it, you can make a lesion. There's nothing you can do wrong. But to be able to see that tissue, Excalibur did enhance the procedure a lot. For me, the single biggest benefit of laser ablation is you make a lesion at a distance. There's no other currently commercially available technology that allows you to do that. Every technology depends on you, 1, getting good contact, 2, maintaining stable contact. If you lose your contact, you make a poor lesion. And maybe even if you make a poor lesion, you're worse off than making no lesion at all. You'll have edema, you'll have no second chance to make a good lesion.
Not so with laser. With laser, you need the balloon to get the blood out of the way to see what you're doing, but provided you can see the tissue, there's nothing you can do wrong. If you can see the tissue, you can make a lesion. It's always going to be a solid lesion. This is, for me, the single biggest benefit of laser. And then the intuitive benefit of X3 is speed. And yes, it's there. X3 has translated into vastly faster procedures. But the other benefit, maybe less intuitive, is that it's a new way of lesion formation that maybe is even a better guarantee of continuous overlap, of contiguous lesion formation, due to the fact that you're using a bit the penumbra of your current position as a runner-up or a follow-on of your yet-to-come position or your previous position. Meaning, if you look at the simulations that were done, and these simulations have been done to understand this actually fundamentally new way of delivering the energy versus the discontinuous step by step, you see that with this new energy delivery platform, with this new way of making a lesion, with the energies we're using, we're actually more likely, I believe, to make a single continuous lesion, to make a lesion without a gap.